It has a very large spectrum of challenges for EBD patients, from diagnosis to treatment. But I want to concentrate in some particular things. The inflammatory bowel disease are invisible disabilities. I mean, the patient doesn't show their disabilities. The symptoms are very difficult to tell because sometimes it's very difficult to meet someone and explain that I have a chronic disease that has as a symptom a chronic diarrhea. That's why people live in isolation. The isolation is the first step of the stigma. The stigma is not the product of not solidarity from friends, especially in work we experience a stigma. The stigma is a product of not knowing what the disease are. So it's important to understand this. We have to be aware that 1 of 4 diagnoses are pediatric. So we have a group of people, youngsters, that will have thank God these diseases are not deadly. I mean, you cannot die when the diseases are chronic, but still we have a patient that for 60, 70 years will impact on their health system. And also, these diseases are familiar, not because they are contagious, but if we have a group, a family of 4 people where there is a patient with the disease, that means that 4 people are suffering to have a disease like this. Well, when I was thinking how to say this morning, I thought about some terms that were taken from the first session this morning with Latin American countries, and I wrote them pride, because still today it's a World IBD Day 2024, and we are all together, so we have to be aware, but also we have to be proud. Solidarity, because we are starting a new era for our cooperation. We are going to help each other in order to address better the needs of the patient we represent. Sharing cooperation, sharing best practice. This is not the EFCCA event, this is the event of all the organization here together. They are contributing with their knowledge and they are supporting each other. Unity, because we have to be united against these diseases. Advocacy, because of course we have to help the countries that need support in represent their patient, how to better help them. In this part, EFCCA is very well prepared with the academy. Networking, I already say that. Learning from each other. We are here today to tell anybody what to do. We are here to learn from each other what is better, because the patient needs are different related to the geography, to the culture, and to the ethnicity. We have to, in a precision medicine, we have to start thinking that we cannot address the patient unmet need just thinking that they're general, but there are unmet needs related to the severity of the disease, phase of the disease, gender of the patient, because a man has different needs of a woman, age of the patient, because a youngster has different unmet need of an older patient, and as I said, culture, ethnicity, and many other things. So we need to understand and address these needs to better support people with inflammatory bowel disease. And before opening this event, that for me it's not an arrival point, it's a starting point, because I expect from now on we all cooperate to better address people we represent. I would like to thank Chronic Colitis of America, Chronic Colitis of Canada for being here, Chronic Colitis Australia, the Latin America countries. Your session this morning for me was very inspiring. Listen to your stories for me was a gift that I will share and I will take back to my country when I go back home. So Chile, Mexico, Colombia, Uruguay, Brazil, and Costa Rica. I would like to thank the president of ECCO, Britta Sigmund, which will not be here in presence, but she sent also a video. Professor Fiocchi, her friends, that is always close to us, supporting us and helping us to better understand the disease. Beatrice, the organizer of this event, and you make us feel like a home. And thank you so much not for me, but from the EFCCA family. And please, thank you for the EFCCA staff. Let me tell you, thank you for the EFCCA staff here. And no, I'm here, Luisa, Bella, and Roberto, but we have other and Laura. I don't see Laura over here. Oh, is it? and the staff working home. And of course, thank you so much for the EFCCA board, to the EFCCA board, okay.
So I pass the floor to Beatriz for her welcoming words.
Hola, buenas tardes. Les doy la bienvenida a todos. Para mí, cuando el EFCCA me comentó que si queríamos que México fuera el anfitrión para celebrar y conmemorar el Día Mundial, o sea, por supuesto les dije que sí, pero después uno tiene que reflexionar qué significa eso, ¿no? O sea, no nada más es estar reunidos aquí hablando del trabajo por hacer, sino qué realmente significa conmemorar un Día Mundial. Y para mí el conmemorar el 19 de mayo como el Día de la Enfermedad Inflamatoria Intestinal es para que se sepa en el mundo entero qué es, porque esto nos va a ayudar a todos. Como decía, es un círculo que poco a poco se tiene que ir cerrando con la voluntad y con todas las partes que lo conforman. Entonces, sin mucho más palabras, les doy la bienvenida y siempre anteponer a las personas que no están aquí, pero que están indirectamente aquí porque por ellas estamos trabajando y por ellas estamos haciendo que la enfermedad inflamatoria intestinal sea conocida para que se diagnostique y se trate de la mejor manera.
Wow, it's really high up. Good afternoon, everyone. I'm really very happy and very proud also to be here at this meeting, because today I think we're going to have some very necessary discussions that will maybe or hopefully really have a positive impact on IBD patients worldwide. But before we go to those discussions, I want to take a brief moment to talk a little bit about how World IBD Day came about, just to provide the context. So, for that I have to go back 14 years. It was exactly around the 18th, 19th of May, 14 years ago, that EFCCA traveled to San Diego in the US to participate at the Digestive Disease Week, which is one of the major medical congresses. And together with other major IBD patient organizations, such as Crohn's and Colitis Australia, Canada, and the US, and the physicians from Brazil, ABCD, and one of our members who joined us on this trip, we sat together, just like we do today, and we thought it was really, really important to create a day where we can annually commemorate and celebrate, maybe not, because it feels strange to celebrate something like this, but to mark the day for World IBD Day. And we decided to do that because back then, and I think even today it's the same, there's still very little public understanding of what it means to live with this disease. So the idea was to have a specific day once a year where we can globally raise awareness, not only with the public, but also with healthcare professionals and other IBD stakeholders that are relevant to the work we do. Another reason was also to show to the world that we are united, that you are not alone. I think this was something very powerful that also came out this morning in the discussions. You don't have to feel like you're the only person on the planet that's coping with this disease. So it was really also a day to unite with other people, with stakeholders, with volunteers, and to really create that sense of unity. And there have been so many amazing activities all over the world. There are only a few of those examples. We started lighting a famous landmark in purple. The one in the middle is from Mexico, actually, which was taken a few years ago. We had volunteers from Austria who created a purple ribbon. We had some very creative ideas of our colleagues in Lithuania that hired a sailing boat to raise awareness. And of course, on this day, there are many information events at malls, at the hospitals, where they really try to raise more awareness about the disease. Back then, when we met with the founding members, we also decided that we need to establish a website specifically for World IBD Day. And this website has been coordinated and maintained by EFCCA. And we try every year to make it like a hub of all the activities that are taking place worldwide. And I really invite you to have a look. You have the address at the bottom of the slide. And you will really see the wealth of activities and inspirational initiatives that are being taken, that are being carried out around these dates. So to come back, why did we back then decide to create a World IBD Day? Because we believe that the strength lies in numbers. The more people we are to raise awareness, the more we will get these results. So in 2023, I was looking at all the activities that were taking place. We united more than 60 patient associations on 5 continents, which involved more than 500 IBD information events. More than 1,000 volunteers participated, and we've also seen an increase in social media and in the mainstream media. Coming to this year, the theme 2024, IBD has no borders. This is something that we've initiated a couple of years ago when we talked to our members. They said that it would be useful, rather than to have a general awareness raising for World IBD Day, to look at specific themes and highlight specific areas of a patient's life and to unite around this theme. And for this year, we decided that it was really important, seeing also that we are growing more and more. We're not just acting in Europe, but we have many members outside Europe, many other organizations that are not member of EFCCA, but that are in contact with us, and they really want to do something specifically for World IBD Day. We thought it was really the moment to recognize that IBD is on the rise globally, and it's a universal nature. So we really think there's a need for more collective actions, not just in regional, but on a global level. So the need for global response that prioritizes awareness, support, and equitable access to care for all that are suffering from the disease. And our IBD Has No Border campaign has 2 components. So one is a social media awareness raising campaign. And we want to hear from voices from different countries. And we have asked IBD patients to see what it means to them, access to IBD care. So we really wanted to highlight the diverse challenges and possibilities of living with IBD. And at the same time, we also wanted to show that there's a real need for improving access to care. I want to give the floor to one of these patient testimonials. So I invite you to, can we play Noemi?
I'm Noemi, and I live in Bari, in the southern Italy. And I'm a part of the Italian Patients Association Amici Italia. For me, the most important element in IBD care is to consider the person as a whole human being and not just as a patient. What could be improved in the IBD care is to ensure the homogeneity of care provision among all regions and streamline the bureaucracy that is involved in the management of such complex pathology.
Buen día para todos, mi nombre es Lorena Garzón, yo vivo en Soacha, Cundinamarca, en Colombia, y lo que yo quiero es que esta enfermedad sea más conocida a nivel mundial para poder prevenir por todo lo que los pacientes de colitis ulcerativa y Crohn hemos pasado, porque las enfermedades inflamatorias intestinales no tienen fronteras.
So this is just an example of some of the videos that people have been uploading. And I invite you also to check out our social media, and we really hope that this can also create more dialogue and to see what it actually really means on the ground. The second part of our IBD Has No Border campaign is also this roundtable discussion. So we really wanted to gather all the founding members of World IBD Day. We haven't met in one room since 14 years, and we think that's too long. We have been working on some ad hoc activities, and of course we've been working on some specific actions, but we really thought this is now the moment to come together and really discuss what we can do to improve the situation worldwide. So the objectives today are to identify barriers to accessing quality IBD care globally. We want to advocate for increased awareness and support and resources. And hopefully we will be able to formulate some shared recommendations for improving IBD care worldwide. So at the end of this meeting, we really hope that we can recognize the importance of addressing IBD as a global health concern, and that there's a need for strengthening collaboration with key IBD stakeholders. And of course, I mean, this is always, when you meet, then you think this is all great, big words, but then afterwards nothing happens. But we really, really hope that we need to engage more, to continue this work that we're starting today. So I'm really excited to looking to the discussion that we're going to have today. Thank you very much.
The importance of strengthening relation with stakeholders, and the first speakers we are hosting virtually is the president of ECCO. ECCO is the European Medical Societies for Crohn's and ulcerative colitis. We invited the president, Britta Sigmund, but she was involved in the DW, so she was traveling to Washington, but she has sent us a video, and you will see how important is getting also for the European medical societies to find a way to overcome the borders. So could you please start the video, please?
And a very big thank you to Salvo and Luisa for inviting me to give this talk today at the EFCCA meeting as at the World IBD Day. My name is Britta Sigmund. I'm the current president of ECCO, and I really like to apologize that I'm unable to be there in person in Mexico City today. However, I'm really pleased to be able to provide a couple of thoughts on IBD Has No Borders and what ECCO thinks about this at your meeting in a virtual way. And it's in fact interesting that the topic today is IBD Has No Borders. Over the last year, ECCO has thought about how to better illustrate and outline the goals of ECCO, and for this we developed a strategy which is called the REACH strategy, shown here. And The REACH strategy basically includes 5 clear goals that will shape the work and the route of ECHO over the coming 5 years. And I would like to explain what each letter of this acronym implies and what this really means, how ECHO wishes to work over the coming years. The first is the R, which stands for rapid diagnosis and treatment. And here the goal is really to improve the time to diagnosis and treatment of IBD, investing in all aspects of IBD care early and throughout the disease course. And I think all of you know that this is a key point. We all know that the sooner we treat IBD, the better the long-term outcome is. Having said this, we also know that it's very difficult for a lot of people in the world to get rapid care, rapid diagnosis and rapid treatment. And we absolutely aim to improve this. So this is the R with the clock here. And the E, probably the most important one with regard to your topic today, is the E is the equity, the equitable access to IBD care, which actually relates a little bit to the R, because if there is no access at all, you cannot get rapid diagnosis and treatment. But the goal really for the E is to enable equitable access to IBD care for all patients. So how can ECHO support this? And I'm absolutely aware that we cannot achieve this alone. We need the global effort to reach this. However, we try, as ECHO, to join forces here with all groups involved to get this forward. And this implies, and just to outline a couple of points that we have implemented, one is the global grant, so building networks throughout the world to strengthen IBD research and network to get a better equitable access to care. We have implemented a number of travel grants that also allow people from outside Europe to get education, to develop a better care in their countries. We have a working group for low to middle income countries, which I think the output of this working group will be very interesting. And we have a lot of educational material that we are happy to provide and that is open to use to all IBD centers worldwide, and we will think whether or not and how to adapt this to the low to middle income countries. However, I think the most important thing is the sentence at the bottom, that we can only do this when we head in the same direction, and if we join forces. And if we join forces with our dietitians, if we join forces with the patient organizations, if we join forces also with politics in order to increase awareness and improve care. Having said this for E, we come to the A, to attain sustainable IBD care. So the goal here is to achieve sustainability in all aspects of IBD care, including delivery sustainable services throughout innovative assessment, monitoring, in addition to delivering sustainable research and education. And the A, and I'm coming back to this in the end, will be the main topic of next year's ECHO Congress. With this we come to C, and C in our view is probably the most difficult and challenging letter of the REACH strategy, which goes to causes of IBD. And the goal is to use the best state-of-the-art science and technology and global collaboration to discover the causes of IBD. And I think a lot of groups around the world have been trying to do this over the last couple of years. But this will take more time, but we definitely want to dedicate our research to get this solved. The last one, the age, really an important one and a neglected letter, and that's why we put this in our strategy, is the holistic IBD care. So you can have excellent IBD care and your inflammation in mucosa can be completely resolved. Still you can feel fatigued, still you can feel not able to follow your normal day. And thus we believe that an important goal really is to treat IBD beyond inflammation, ensuring holistic care and optimized psychological well-being. How I already said that we really need to do this together. ECHO has a number of initiatives, but we can only fulfill those initiatives and bring them across the community in the world if we all do this together and if we join forces. And I think me being here with you today and that we had the EFCCA forum at this year's Congress in Stockholm is already indicating that we are joining forces in driving such efforts forward in a joint way. From an ECHO point of view, we have this new strategy now. We have 5 clear goals that we wish to address over the next 5 years, and with this we would like to expand the mission of ECHO, and each year we will tackle one particular goal, and this year it is equity. And the commitment here really was, as outlined when I introduced the E, to strengthening our international collaborations and also international research. Next year it will be the Attain Sustainability, and we will work towards a better sustainable delivery of care. And I'm also really looking forward in working on this goal jointly also with EFCCA. Having said this, I wish you a very pleasant IBD day, and I'm looking forward to move all these strategies jointly forward in order to improve the IBD care. And as a consequence, and I think this is really the main goal of ECHO and also the main goal of EFCCA, to improve the life of the patients, which ultimately is the most important thing. I thank you very much, and very warm regards from Berlin.
Well, I'm sure you saw how many commonalities and how many possibilities of working together were showed in this video. As Professor Sigmund was saying, we have been working hard in the past years to strengthen our networking and common activities, and some of you already know we had the chance to be finally included in the scientific program of ECHO, and we had the chance to present some preliminary results of a survey that was mentioned this morning about people over 60, and it was really, really important. Before I give the floor to Claudio Fiocchi, I just want to remind you that all these presentations, the video, etc., all the material will be then uploaded on our website, so you will have everything available. Let's give us a couple of days after the meeting today, but everything will be made available for everyone. So now it's my pleasure to give the floor to Professor Claudio Fiocchi. He's a professor of molecular medicine at Cleveland Clinic and Liner College of Medicine, Cleveland, Ohio. And I think it's going to be a very exciting moment. And I give the floor to Claudio to tell us his view about IBD has no border.
Good afternoon. Boa tarde. Buenas tardes a todos. Yo no tengo muchas oportunidades de hablar en español, pero si lo me permite, me gustaría decir unas palabritas en español. En primer lugar, quiero agradecer a EFCCA por invitarme a un evento tan especial. Y me preparé, pero me olvidé muchas cosas que quería decir. Pero una cosa que quiero decir es que para mí es un verdadero honor y un placer estar aquí con ustedes. Y en segundo lugar, me gustaría explicar por qué yo estoy aquí. Bueno, yo nací en Roma, en Italia, hace muchos años. Y cuando tenía 15 años, mi familia se mudó de Roma para Sao Paulo. Y viví en Brasil por 16 años. Y en Brasil me gradué en medicina, me casé y luego me mudé para los Estados Unidos. Y en los Estados Unidos estuve estudiando las enfermedades inflamatorias intestinales durante más de 40 años. Así que espero que sea, yo sepa algo. Otra cosa importante que, como saben, como perciben, mi español no es perfecto, así que daré mi charla en inglés, pero todas mis diapositivas son en español, así que hay una variedad de oportunidades para entender. Bueno, so today is Purple Day. There's a lot of purple in the room, on the tables and the screen, and I think and I hope that the purple is in your mind. It's very important to think, as we heard many times, that we have to think purple all together. Okay? So we all think about IBD, how to make it better. All of you are expert in IBD, different degrees, and we know that IBD has been climbing in prevalence. There's more IBD now than ever before, and there are projections of how much IBD we're going to have in the world. And countries like European Union, United States, Australia, and Canada have the highest indices of IBD. Why? ¿Por qué? Because they were developed in a faster, earlier way. And this starts to link IBD to social development. I am completely convinced that IBD is caused by us as humans, our behavior. We have changed the way we used to live when there was no IBD. The first case of IBD was reported, what is assumed to be the first case of IBD was reported in England in the mid-1800s, a lady that had inflammation of the colon. And it became a very famous case report. But after that, in countries, particularly in the British Isles and in the Scandinavian countries, IBD appeared and it became more and more frequent. While in the South and Central Europe, it wasn't so common until the 50s. And we actually can read many papers that were talking about the north-south gradient of inflammatory bowel disease. Because there was a time where IBD in Europe was restricted to the north, and there was Spain, Italy, Portugal, Greece, there was no IBD, which is not true, by the way, but certainly much less. But the times went by, what happened? You know, Europe now has IBD everywhere with the same degree of incidence, and other countries recientemente en desarrollo, like Latin America in Asia, IBD started to appear. And what happened to these countries is the social development, the westernization, se tornar más occidental, es propiciado el desarrollo de las enfermedades inflamatorias intestinales. Lo que nos surgonda, bueno, estoy misturando las lenguas acá, perdón. Everything that surrounds us, from the time we're born, all the way to the end of our lives, we all have hands. Hopefully, without IBD, but some people will have IBD. Everything will influence our behavior, our immune system, and how we react to it. And everything will help in some patients to promote IBD, to make IBD more serious, less serious, and so on. So we have to think that what we have done by changing the world from the old days to the modern days has really conditioned what is causing IBD. We talk about causes of IBD. There is not one cause. There will be, in my opinion, hundreds, if not thousands of causes. Because if somebody is born in Malaysia and has IBD, and somebody is born in Portugal and has IBD, you cannot expect that the same causes are in action. They are very different causes, and they are different genes. So these are very complex diseases. In fact, IBD is part of a class of diseases we call IMID, immune-mediated inflammatory diseases. And they share mechanism of inflammation with rheumatoid arthritis, with psoriasis, with many other inflammatory diseases. Each one of them, however, is different. But what condition probably are the same factors, because when you look at the prevalence of all the inflammatory diseases, it overlaps with that of IBD. I tend to say something that people don't like. We, as human beings, by changing the way we are, we have caused these diseases. Now we want to fix them, and that requires going back, which is impossible to do, unfortunately. Some examples of what we've changed. This is the use of junk food in America Latina. This is old, but it reflects an increase in McDonald's and companies. That is not very good food. We all know, but we all eat it, right? And give me another example. We think that social development, industrialization is bad in conditions IBD. This is not so simple. This is Brazil, obviously, and you can see that there is more IBD in the south. There's more population in the south. But if we tend to associate the development and industrialization with IBD, it's not so clear. This is the state of Sao Paulo, the most populous, the richest state, where most of the industries are. And the upper left, you see the industrial expansion, and then you see the distribution nowadays. You can see that the city of Sao Paulo, the southeast, has a lot of industries. But when we look and we ask the question, where is IBD in that state? Where is it? It's in the northwest, the opposite part of the state, where there's no industries. It's countryside. So what is the connection? We don't know. But so it shows you that it's not easy to find the culprit. This is the cause of. Maybe the people that live with this IBD, have different air, more pollution, which is not industrial, so we just don't know that. And this again shows you how complex it is to try to find the cause. If we ask the question, are patients in Latin America with IBD, are they different in their clinical manifestation from countries like the US? There are not many studies, but basically their differences are not very dramatic, except with the fact that the disease tend to be, for the time being, less severe and fewer surgeries and so on. But this is a matter of time. Why? Because when IBD was developing in Europe, in Scandinavian countries, the disease was not as severe as it is today. And also, ulcerative colitis always, no matter where in the world, precedes Crohn's disease. We don't understand that. But that's the way it is, and we don't understand the epidemiology of these different events. So this, I think, brings us to consider two things. What do we want to invest our time, energy, and monies in finding the cause of IBD or finding the cure for IBD? And here I will ask you to raise your hand who wants the cause and who wants the cure. Who prefers the cause or the cure? So, the cause. Hands up for the cause. Hands up for the cure. We can cure the disease, or at least we can manage it much better. It's the lost cause to find the cause. Really, I'm totally convinced. I don't mind. You can ask the question now, but you have to use a microphone.
I put my, can you hear me? Okay. I put my hand up for the cause because in my mind, wouldn't you need to know the cause to find the cure? They go hand in hand. I'm 100% behind the cure.
I disagree with that.
You disagree?
Profoundly. We don't need to know what's cause. I need to know the mechanism of the disease regardless of the cause. If I know the mechanism.
Yes, you're right.
But the mechanisms are, I can study and identify the mechanism, but the mechanism can be caused by 1,000 different things.
Absolutely, but I'm thinking about studies on prevention where they're trying to identify what are the mechanisms involved leading to IBD. And for example, Dr. Fiocchi, I'm thinking of the GEN project, where they're really working with the healthy relatives when they're still healthy to look at what happens to them that leads to them developing IBD. To me, that's a cause and effect study.
But that's not really the cause. Those people are already prone to develop IBD.
Absolutely.
Some of them will, most of them will not. And the question is why? What causes the difference? And the difference is based on the mechanism, not on the cause. So when we look at the cure, which I think where we should invest more, we have made tremendous progress. When I was an internal resident treating IBD patients, I didn't even have oral prednisone to give. I was giving injection of ACTH, which is a hormone that induces steroids. And this was a little while ago. Now we have at our disposal dozens and dozens of different therapies. However, if you look at the red, the yellow, and the green, which is the not successful, perhaps, and the successful therapies, there are so many of them. That means that many treatments that we have tried, because we are reasonable and logics, they didn't work, regardless how solid the data were. Until we put something in the patient and we ask the question, are you getting better? We know if the drug really works. And in fact, the clinical trials only give us an indication, but it's only when you translate the medication to real-world data, the office of the doctor, the hospital, what we call real-world data, datos reales, then we know if it works for real. Because when we do clinical trials, don't forget, these are in selected centers with selected patients. It's not what goes to the office doctor. So that's another level of complexity. And the efficacy today, all around, is still between 30 and 40%, which is incidentally is about the same that we have in rheumatoid arthritis, in psoriasis, and so on. And a medication that works today will not work next month. A medication that didn't work today may work next month. Why? Because the disease evolves with time. As long as we do what we call cross-sectional studies, we get a bunch of people. Let's suppose that all of you have IBD. I hope not, but some of you unfortunately do. And I study you today, and I found what's going on with you today, and I say, oh, you have this mechanism that went bad, I will intervene this way. But when you go into remission and you have flare-up 6 months down the road and I study you again, I will not find the same mechanism. That's why treatments work at the time, don't work other times. The advantage we have today is that we have so many choices that we keep changing medications. When you go to the doctor, this doesn't work, let's try another one, let's try another one, until by pure chance, something works. Not because I know that that patient has the right mechanism for that drug, because I don't know that, but because it worked. Remember, in medicine, the success of medications is really very, very poor. Overall, if you ask, of all the medications that you can buy in the world, how many of them actually work? How much? What percent? 40%. And these are medications that have been approved by the FDA, but EMA and everything else. So we are still not able to identify neither mechanism nor target that are really efficient. And many patients are in this stage. I took the medication, but they don't work, and the doctor says, I understand there will be new medications. Fortunately, we have a lot of development in these areas. But the big pharma companies are no longer the one responsible for development. The development now is in the hands or in the labs of biotechs. People that use completely different ways of finding mechanisms, not cure. No biotech is going after the cause because it's impossible today to find causes. But if I know that Beatriz has CUSI por causa of this particular cytokine or this particular molecule, then I know that if I block that molecule, Beatriz will get better. But Tiago will not, because he has a different mechanism, different molecules. This shows you how complex is the approach to look for true effectiveness. And the type of medications that are available for IBD, they're very different. In Latin America, there is some uniformity, but if you go to a country like Venezuela, unfortunately, it's a kind of disaster. There's almost nothing there. But throughout the world, the availability of medication for IBD is very variable, and this is for a variety of reasons. Small countries don't attract the big pharma companies to invest a lot of money because the population is small, they don't make a lot of money. It's bad to say that, but it's the truth. Big countries where there's a lot of IBD, there's more investments and so on. This is totally unfair, but that's the reality of life. So it's relatively easy to diagnose and manage the patients. The problem becomes, once you get into remission, hopefully, what happens then? How do we keep the patient that has had a good response in remission? This is the single most difficult problems in IBD. I can induce my patient going to remissions in many different ways, but I don't know how to keep them out of trouble. Some of them will have long remissions. Some of them have very short remissions. Why? Because I have different mechanisms, not because I have different causes. Okay? And that creates very difficult challenges. So we have to develop ways of what you call early diagnosis, but also follow-up. What can we do to help the patient to stay in remission? Because the patient stays in remission, the quality of life increases. There is no need to go to the doctor as often, and so on and so on. Those are very difficult questions, but they should be tackled. Really, it's the equivalent to how do I prevent, do I diagnose early IBD? Very difficult. But how to keep the patient in remission is also very difficult. And if the patient is from a marginalized population, very poor people, very ignorant people, isolated people, that becomes even more difficult because of ignorance, poverty, and lack of job, lack of insurance, and so on. Those are huge problems. They are not medical problems. Those are social, cultural problems. Perdón. Gracias. And those problems must be tackled not by going to the doctor, but by creating social setting that propitiate, access to medicine, which is bring the goals at a whole different level out of the realm of medicine. And so, fortunately, with time, the involvement of the patient to participate in this decision has increased. This is an old study from 2008 made in Spain, where the patient with diabetes were asked, what do you want to know? What do you have to have more from your doctor, for your clinic, and so on? And there were a variety of answers. But this is also changing because we went from a very preliminary way of assessing that to what we call PROs, resultados reportados por los pacientes, where we ask the patients, how did you like this therapy? How do you like this medication? Did your quality of life improve? Did you like the therapy? Did you have side effects and so on? And the patients make reports which are included in how we can better manage the patients. This is becoming very popular and very useful at the clinical level. And then we are going to a phase which has particularly been developed in Europe of the P4 medicine. Medicine which is predictive, preventive, personalized, and participative. And this is what I want to focus on, the little panel. In P4 medicine, research and studies in IBD are not done on the patients. They are done with the patients, where the patient participates actively with the doctor or the scientist. And we have to abandon the right side, where the doctor is the God, where you go and you listen and you don't dispute, you don't ask, you don't challenge, to something to be on an equal scale. And from my experience in Latin America, the culture and the history of Latin American countries, it still maintain this, the doctor. It's like when I got my badge from Luisa, Professor Fiocchi, I really hate to have the professor in front of me. I think that we are all equal in life, and we all should respect equally. So when the doctor meets with the patient, it's not this, it's like this. And the patients, particularly in countries like Latin America, has to learn to feel equal, because they are equal. This is very important. I know this is not easy to do. It's when I travel around the world, in some countries I'm Professor Fiocchi. In the US, I'm Claudio. And it's very difficult to change that. But a patient has the right to demand equality. It's not easy to do because culturally you're educated in a different way, but that's the way it should be. So I did a survey of how many studies are done in participative medicine, the P4. This is PubMed, where you go online from the NIH, Instituto Nacional de Salud de los Estados Unidos. And I said, how many publications are on, I don't know if you can read, Salud Participativa? Casi 20,000. Entonces, me pregunto, ¿cuántos en cáncer? 1,520. ¿Cuántos en enfermedades crónicas? 880. ¿Cuántos en IBD? 19. This means that, we are still way behind. We have to force ourselves, particularly the patient association, to force this issue of changing the mentality of the patients and make them be proactive. In the US, there's a lot of proactivity. And it has ups and downs, but I think that being proactive as a patient is good for the patient. It's something that has to be learned. And it will be a slow process, but if you go after, it's never going to happen. So, you are familiar with this much better than me, okay? And it's up to this organization, the one that represented in this room, to really activate what I propose as equality and participation and demanding. And DIVA is going that direction. qué, cómo, por qué, cuándo, quién, dónde. These are all questions that you have the right to ask. And the right to have questions answer, assuming that it can be answered. But there's only some answers. When the doctor, unfortunately many doctors don't do that. Many doctors, I know, they don't really bring the patients to them, which is wrong. And many doctors don't think this way. And it probably is going to be harder to change the doctor mentality than the patient mentality. This is a diagram that I found in a Journal of Democracy, which is I never heard about it. But here are the patient, the big pharma, and the government. How do they relate? The patient has no power in controlling medication production. We as individuals, healthy or not, we have nothing to say about that. And we have very little influence over the big pharma. Big pharma is extremely powerful because they have hundreds of billions of dollars stashed away that they can use for whatever they want. And what they do now is buying many companies with the hope that one of them will give us a product that will make enough profit that will last at least 10 years before it goes out of control. And the government, believe it or not, that doesn't have that much power to control big pharma. In the US, the government has no mechanism to legally control the price of medication, which I personally think is absurd. But it's a reality that we lived in. In Latin America, socialized medicine, I think that that's not quite like that. And in many ways, the Latin American and many other countries like European that have socialized medicine, they have the advantage that very expensive medication like the biologics are paid by the government. In the US, this will cause either losing or winning an election for presidency. But it's not an issue that is talked about. And the basic question is very simple. Here's the door to the Ministerio de la Salud. La agencia para el paciente. Atención al paciente. If one patient knocks, toc, 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 the door will not open. But if thousands of patients knock, the door will open. And that means that thousands of patients are the patients working together, the association coming together and knocking at the door with words, with fact, and something in the US, there is a lot of this stuff because the culture is, okay, I don't like my school is run. Let's get all the parents complain and go to the school and make noise. You know, this is something that doesn't look very nice, but it's very effective. You know, the wheel, the squeak is the one that gets the oil. I don't know how to translate this in Spanish. But if you say squeeze, 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 then say, okay, let's stop that, let's stop that. And this is an approach that I recommend. If that was done, then here I say EFCCA, but the poder de las asociaciones todas juntas, con visibilidad y representación, el gobierno le escuchará. And the government can then impact on the pharma and can impact more on medication production and availability. So it's a matter of getting together. And this is no surprise. Unión es fuerza. Gracias.
Thanks a lot, Claudio. I think I'm just looking at the audience. If you have any questions, burning questions, I will get some of them now, but then I would recommend we keep on having the presentation, and then there will be the occasion during the panel discussion to maybe discuss more in depth some of the topics. But in any case, and not only for Claudio, but for any speakers, if there is any burning questions, please raise your hand and ask. Don't be shy. I didn't want to stop you. Okay, so I give the floor to Lien Reven. She's the CEO of the Australian Association, Crohn's Colitis Association, and she will talk about the children's situation, IBD children in Australia. Thanks, Leon. The floor is yours.
Hello. Thank you. Thank you so much. It's such an honor to be here today. I have to say I have no Spanish, so I'm sorry. You'll have to connect to your box. I'd like to thank Mexico for hosting us, and this meeting has been a wonderful experience, and we will learn a lot. And also to EFCCA for organising it. You are very visionary, and I thank you for that. Now, what I'm talking about today is looking at the experience of children and families in Australia. This project was funded by the government in Australia, and I have no other disclosures. This is what we do at Crohn's and Colitis Australia. So I was very interested to hear the professor talking about empowerment of patients. So this is what we dream. We dream that there will be no Crohn's and colitis. We want it to be cured. But we empower people to live fearlessly while we help search for a cure. This is our ambition. We've just reviewed what we're doing, and we don't want anyone to feel alone. I won't go through all of that. You can get the slides. This is Sydney. This is a major city, and this is one of my favourite photographs. We actually lit the whole city up purple on World IBD Day. And it happened, it's a really funny story how it happened. We have a festival, it's a festival of light called Vivid, and they were testing the evening before World IBD Day. And they said, we'll light everything up purple for you for free. So it was a fantastic partnership, and we were very excited to get a webcam photograph of it. So you may know our opera house, you may have heard of that, and our big bridge. This is where we are, the little red dot in the far corner, and it took me 24 hours to get here, so we're a long way away, down under. We have an IBD government action plan. We wrote it for the government. We developed it for them. They accepted it. And in that plan, one of the priorities is that we look at children. So we did this paediatric project. We got government funding. It was a contestable government grant, so we had to compete for the money. We worked with the Gastro Society and other organisations, particularly the Paediatric Network. And we got the funds to do a study looking at the experience of children and families, and also an audit of all the children's hospitals. We put together an advisory committee, which is really big. The study involved an experience which was looking at using an online survey and family interviews, and we did that in 2022. It also involved looking at PBS data, which is pharmaceutical benefits data, so the drugs. We did a hospital audit looking at the organisation and a clinical audit in 2021. And we also used other data from the Australian Institute of Health and Welfare, which looks at activity. Now today I'm going to just talk to you about the experience, because the hospital audit we haven't launched yet. I'm going to share with you some slides about that, but I ask EFCCA not to publish those slides until after the 30th of May, because we're launching in Australia at Parliament House. So I'm giving you information that Nobody knows yet, but I'm very happy to share. So the experience survey, there's some demographics, and you'll get copies of these slides. So I'm not going to go through everything. I've got too many slides. I'll have to get moving. So these are the demographics. These are the clinical characteristics, the percentages of people with Crohn's, with UC, and the unclassified groups. The survey results, we looked at, clinicians in their team of care, their medical management. We looked at medication use over the previous 12 months. Also looked at medication use in the previous 6 weeks. And we also looked at, whether their care was inpatient, hospitalisations, planned surgeries, and the percentages of people who were accessing that care. We focused on transition because transition from a child to an adult, that 16 age group, is a very important milestone. The psychological burden was overall 50.8% of people who were surveyed had a psychological burden, usually anxiety or depression, and we measured that. So we also looked at people who were accessing other healthcare professionals and whether they'd actually been asked about their mental health in a clinical situation. There's some other results. We compared young people who had a low psychological burden to those that had a high. And we also looked at geography. So, whether people who had active IBD, whether they were located in urban or regional centres, what their current treatments were, and a whole lot of statistical analysis. With the family interviews, we got lots of information from families. And, here's a quote about the path to diagnosis, which is a big issue. It can take a long time to get diagnosed, depending on where you live, what information you have, what support you have. So that's a huge issue. And the next steps, as I said, is we have our launch of our audit, and I'm going to show you some slides on that. And these are the secret ones. So, as I said, we surveyed and we audited the hospitals. We had some data from 2014, so that enabled us to do some comparisons as well. But we basically surveyed 23% of national public overnight admissions. In the patient experience, we had 266 teens and parents surveyed and 35 family interviews. The findings on active disease, 49% had anemia, 37% malnutrition. None of these will be surprising to you. 47% were hospitalised twice in the last 2 years, and 45% came through emergency departments. There was limited multidisciplinary care. So only 23% of patients with Crohn's actually saw an IBD nurse. 28% of those with psychological comorbidity didn't see a psychologist because there's none on the teams. And that's down from our 2014 data, where we actually had one psychologist. So nothing's happened. Clinical gaps in hospitals, comparing 2014 to 2021. The preventative antithrombotic treatment was lower percentage, which was really surprising and really quite annoying because we've got clinical guidelines around that. 56% of the young people were accessing their medication on compassionate grounds, so off-label is what we call that. So there's no mechanism for them to actually get the treatments, unless the pharmaceutical companies. So thank you all, and it's lovely to meet you all.
For Leanne at the moment, or we can resume after. We just had to cut the streaming because your slides were unofficial. That's why we had to.
Oh, thank you.
Say
Thank you. I didn't know we were streaming.
So now I would like to invite Laura Winskate to the podium. Laura works for Crohn's and Colitis Foundation, and she is the Vice President on Education, Support and Advocacy.
Buenas tardes, gracias, and thank you for inviting me to be at this meeting. I'm very honored. Oh, I'm very honored to be here today. And I just want to, before I share my slides, I wanted to share that there are so many synergies that I'm hearing about as we each share and have our dialogue together. And the mission of the Crohn's and Colitis Foundation, as Professor Fauci said, is so important to cure Crohn's disease and ulcerative colitis and improve the quality of life of children and adults affected by these diseases. And I think we all share that desire to improve quality of life. And today I'm going to share some preliminary data with you from our Access to Care assessment. And this is not published yet. We're publishing later this year. So again, you're getting a sneak peek of what we have done in the United States. But I do want to share that this information is really about access to treatment, access to physicians, not addressing the health equity issues or the social determinants of health that may be impeding care. We're doing other work in that area, and I hope in the future I'll be able to share that with you. So this is really more about access to treatment, access to seeing healthcare providers in the United States. And there may be some terms that I use that are very specific to the United States healthcare system. So please, if you have questions, don't hesitate to interrupt me. I'm happy to give a brief explanation. All right, okay. I have to wear my glasses. So our access assessment, our goals were to assess the data addressing access to care barriers, things that were getting in the way of patients in the United States being able to gain access to the treatments and care that they needed to receive. And we wanted to prioritize these issues and advocate at the state, all of the 50 states in the United States, as well at the federal level. And the reason we need to do state and federal advocacy in the United States is insurance in the United States, we don't have socialized insurance, and the federal government controls certain insurance, the state governments control other insurance, and then there is the federally funded insurance, Medicare and Medicaid, which cover those who are older adults or young adults, children specifically, that are underinsured and need government assistance. So we really have to advocate at many levels in order to affect change for the IBD community. We also wanted to use this assessment in our next strategic plan. We're developing our new strategic plan now, and we wanted to make sure that this assessment help inform both our advocacy, our research, and our education priorities as we move forward. And lastly, we wanted to be able to share this information with the healthcare professionals, our GI physicians, our primary care, our dietitians, our GI psychologists that treat IBD patients so that they could understand these barriers, know the resources that might be able to help them address these barriers for their patients. So we conducted an online survey of people with IBD and their caregivers who reside within the United States. We opened the survey in February of 23 and closed it in June of 23, giving sufficient time to get the responses that we needed to make it statistically significant. We used the Crohn's and Colitis Foundation constituent database as one source, but we also partnered with other IBD organizations around the United States, so Improved Care Now, the South Asian IBD Alliance, among others. And I can't name them all here, but thank you for helping us to field this survey. We used social media, and we also did some targeted outreach to ensure a diverse sample size.
Any question? Now I will give the floor to Roberto Saldagna. Roberto is the coordinator for innovation and patients' involvement. Roberto, the floor is yours.
Okay, good afternoon. Mi presentación. Okay. I usually start always a presentation saying the same thing. Every time we have been asking patients for these last decades, asking for what they are expecting from their health system, from their physician, what they need from them. These are the main topics that usually appear in the conversation. More clinical research, better access to treatment, and a better quality of care. Maybe there is a room for improvement in quality of care. There is an opportunity for speaking about clinical trial inequalities, how promising are some drugs under development. However, I'm going to speak only about the better access to treatment today because we are struggling right now in Europe. We are dealing with a very difficult scenario. According to the WAIT report, an annual report that has been released in the last 5 years, less than the half of the treatment authorized by the European Commission are only available by mean in every European country. This is the differences. Almost 170 new drugs came to the market in Europe, and depending on where you live, you can get access to those drugs or not. There is a very big difference between living in Germany or in Malta. In Malta, just like Claudio said, it's a small country that maybe with a few patients, and companies sometimes are not interested in going there. But this isn't the worst part, because the reality is even worse. Because when the drug is available, if you are lucky, national governments are limiting the use of those drugs, restricting the indication authorized at the European level. The real picture is this one. It's a drama. It's something that is worrying all of us, policymakers, pharmaceutical companies, and of course, the patients. The problem with these studies is that they are not specifically speaking about IBD. We have been launching DIVA to analyze what is happening in the IBD field. The European Commission has authorized more than 30 drugs, including the generics and biosimilar for treating IBD during the last decades. And when we go down or break down the information by countries, we observe our national realities. This is Spain, where new drugs are under development, under review, sometimes for years, 2-3 years. Or even worse, you have been waiting for the decision, and then, that is what's happening with, for example, Zeposia. The final decision was to refuse the use of the drugs for treating IBD patients. And this is weird to understand because the same drugs has been authorized in Spain for treating multiple sclerosis. So why sometimes we are using drugs for treating other conditions, but not all the indications the drugs have? However, the problem is not that we are not getting access to innovation. The problem is, again, even worse, because classic drugs are not accessible anymore in many, many countries in Europe. We have shortages that are affecting the current clinical practice. For example, in Spain, we are missing right now more than 800 drugs. And you need to check every day with your prescription what is happening or what will happen when you will go to the pharmaceutical office. There are several explanations for this. Some explanations are understandable. There is a shortage because there was an accident in the factory. It's okay. It's a course. Other is because of the prices of the drugs in some countries. If our country are so cheap that suppliers prefer to sell the drugs in other countries, they are going to do it because they are allowed. That is another problem. There are IBD trends or prevalence in any disease is increasing around the world. So other countries like India, China, and other crowded countries are now getting access to drugs for first time. So we need to compete for raw materials. And this is a new area for all of us because we need to increase the production, and sometimes it's impossible, or we need to share the drugs. At least we are not alone because we have been checking the literature and there is some shortages in other countries like in Australia, which have been checking what happened a few years ago in Australia when you have the mesalazine shortages. And you prove that when you are missing your drugs, you get into a flare again. And this is a problem because if we are not protecting innovation, if we are not protecting the old drugs, what we have to protect IBD people or the rest of the population with other conditions. We have some debates because this is something we need to speak. There are some policies initiatives in Europe who have been part of the debate. In last year, for example, the European Union held 2 meetings to explain and open a dialogue with the rest of the society to speak about the situation and also the possible solution. However, there is some gaps between with stakeholder things. For example, according to who you ask, maybe the problem, the consequences as a solution could vary. For example, the national governments are deciding, proposing a new regulation in Europe to protect and expand innovation. But only those drugs that are covering real unmet needs. And what does it mean? We don't know. The classic definition of unmet needs is something that have not available treatment in the market. But we have available treatment in the market. So if we are not going to promote more research because we are covered by the current ones, we are maybe discouraging a sponsor of clinical trial to keep working on IBD instead of other that can maybe might be more profitable for them. Because what the European Union proposed is to connect the year of the patent to the covering the unmet needs covering. So if you are not covering a real unmet needs, you are not going to have more than 6 years of patent. And that is enough. Because if there is a delay with the entrance of the drugs in the market, you are going to lose money. We are discussing, the proposal is under development. There has been a public consultation now with the draft of the new reform. We have been sending our feedback. We are aware of the importance of protecting the more vulnerable IBD patients, those ones who are not taking any advantage of the current drugs, because if they are not taking any advantage of the current drugs, and they are not going to see any new drugs coming to the market because there is no any incentive for developing them, maybe there is not going to be a hopeful future. So the reform is there. We are still discussing. And there is another new topics raising, the STA. This is an opportunity because we are going to link in Europe the authorization of the drug with the assessment of the value of the drugs according to what other treatments are offering in the market. Here there is an opportunity. We have been also being part of the debate. We don't know how we are going to collect the national realities to understand clinical practice in many, many countries, because it's not the same the clinical practice in Poland than in Spain or in Germany. So we need to generate information with real-world evidence about the drugs used in every country in Europe, so that at the same time we have the authorization, we are going to know if the drug is valuable or not for IBD people. And this is why we have been working in new materials, like the new guidebooks for STA from the patient perspective, so that we can understand what should ask and expect from new drugs. Here we have been including a checklist, for example, to observe if the drugs are covering the urgency to go to the toilet, the pain, if they are covering the main concern with the patient usually have when we are dealing with these conditions. And that's all.
Question for Roberto?
Yep.
Roberto, I think you were talking about in the HTA process and in every different country, the mechanism that they use to cost, the lowest cost comparator process. We are having big difficulties with that in Australia, in IBD. We're actually the first clinical area to be hit in terms of pharmaceutical companies not coming to agreement on price, and then we just don't get access. Is that the same in Europe, in all countries?
It's the same. There are several reasons not to have the drugs in Europe. Sometimes evaluators say that there is a lack of evidence because the trial wasn't good enough.
For us, the evidence is fine. It's the lack of
there are
money to
sometimes
pay.
Excuses, or there is another issue, the price of the drugs.
Yeah.
And we all need to be aware of that, because of course it's a problem for almost every health system. Prices are every year increasing, not because of the drugs of IBD, it's because of the advanced therapies, it's because the new drugs are getting more expensive in general because of the technology behind it. But it's not our fault. We need to look for the solution. But before that, we need to understand what the real problem is, because sometimes there is a lack of evidence. Claudio said it before. Sometimes we need to keep researching what patients are getting from current drugs. We are been reducing symptoms in some patients, not in others. Or we have been keeping some symptoms and relieving others. Not every new drugs are coming to the market solving every question we have. Are they covering the same features? Are they solving the quality of life? Are they covering the same things that the current market are doing it? The evidence need to change the evidence we generated during the clinical trials. Now with this new STA reform, what we need to do is a better phase 3 clinical trial with real competitors in every country, so that we can understand the real differences of using every drug. And if we have that information, there is no excuse. If a new drug is better than the current drugs, we need to use it. They are not going to cover anything new. Maybe it doesn't matter if they come to the market or not.
Yeah, definitely big global issue.
It's a global issue.
Yeah. And we're reforming HTA at the moment. 30 years ago, it's been 30 years since they reformed, so we're going through a big process, but it's a global issue.
Canada is also reviewing their processes.
Any other question? So we move to Canada. I give the floor to Kate Lee, who is Vice President of Chronic Colitis Canada, and she will give us a presentation about her impact study.
So thank
Kate,
you.
please.
I have some notes because I tend to ramble, and when Bella reached out and reminded me I only have 10 minutes to speak, I felt, oh dear, I might need to cut down on the words that I use. I do have notes here, so I'm going to sit instead of standing. I hope that's okay. So, what's that? Yep, absolutely. So it's interesting that we were talking about the healthcare system, and one thing I just want to start by saying, as I'm listening to all the speakers, we may have different healthcare systems, like in the US, it's very much private healthcare. In Canada, Australia, Europe as well, I think it's public healthcare, yet there's so many commonalities and some differences. Like there's something that you said, Leanne, that really piqued my interest, because I know our healthcare systems are quite similar in model, yet you spoke about something that really that's very different from Canada. So thank you, first of all. I wanted to thank Luisa, thank EFCCA, and thank Mexico for inviting me to the session. So this promise is one that we've had for a very long time. Our organization was founded in 1974 by parents who had children with Crohn's disease and ulcerative colitis. And you can imagine in the 70s, and very similar to these days as well, they had a very difficult time advocating for their children and finding the proper diagnosis for them. Laura, it's interesting that you talked about the CCF mission statement, which is almost exactly the same as ours. And it's not, we collaborate, yet we didn't talk about this. So our promise is to aspire to cure Crohn's disease and ulcerative colitis and to improve the lives of everyone affected by these diseases. We did change one thing. We had a very similar promise before. We're in a new strategic era. Before, we used to say, improve the lives of children and adults diagnosed by the diseases. But then we realized that the caregivers were being left out. So because of that, we intentionally tweaked our promise to ensure to include the caregivers in this, and other loved ones, partners, and so forth. I wanted to step back and just talk a little bit about how do we come up with our mission priorities. There's so many things that we could be addressing, and we do have to think about within our landscape, how do we address the top priorities. So we do periodically, every 2 to 5 years, some sort of formal assessment. I think we all do that. I think we've all talked about that. And so on the left, this speaks to all the different inputs that we take into consideration when we think about how do we address the top priorities in Canada. We couple this, of course, with what can we do? We have limited resources. We also think about partners that we could be partnering with. Had a really lovely discussion with Laura about opportunities for us to partner as well, and had some further discussions with Luisa as well. And so this is what we do to see where can we not reinvent the wheel and support each other, and where do we actually have to invent the wheel ourselves. And that's how we come up with our programs. We have 3 different mission priorities: patient programs and services, research. So we do fund researchers in Canada who conduct IBD research, and we also advocate. The data or the impact that's on the title of my presentation really has to do with our publication that we periodically publish every roughly 5 years. And so this has been an effort that we've been doing since 2008, so we're in our 5th iteration. And this is very much a partnership with a consortium in Canada called CanGeek. And this consortium stands for the Canadian Gastrointestinal Epidemiology Consortium. It's a fairly large active group, and we're lucky that we've had this formal partnership with them where they conduct all the research, the evidence collection, and so forth, and we work together, of course, bring together the patient and the caregiver perspective, and together we publish. Our most recent publication was in 2023, last year. We launched it in June. I would say it's the most comprehensive report that we've published to date, where we have 11 chapters and areas that we didn't cover historically. One of the ones that I want to draw your attention to is one that I think our patient and caregiver community basically said it's high time that you had a chapter dedicated to that, which is mental health. So we have mental health. We do have a chapter on gender as well. But one of the things that gender talked about was that there's lack of evidence, lack of research. So the call out for that, there needs to be research in that. 11 chapters, just wanted to speak to the effort. It took about 2 years for us to publish this. And the number of people that worked together to publish this, we had over 100 co-authors working together, combined with physicians, academics, scientists, patients, of course, and caregivers. So key findings, and what I want to share with you today is I'm not going to give you a high-level overview of everything that's published. I wanted to just cherry-pick some summaries. Claudio, you talked about Canada in terms of prevalence, and we are at the higher level, so we're almost there at the flat end, but not quite. So the prevalence, the acceleration of prevalence is slowing down, but it's still increasing. So right now, we have over 320,000 Canadians living with IBD. In 10 years, they're predicting over 1% of Canadians will be diagnosed with Crohn's or colitis. And what are the drivers of this increase? It's that has changed as well. It's the pediatric population where the incidence, the new diagnoses are going up. As a matter of fact, it's doubled since 2008. And then our senior population. Because we're living longer, we have more and more seniors who are living with Crohn's disease and UC. The face of IBD is changing in Canada. Historically, it was very much a Western European or Ashkenazi Jewish descent disease. But now what we're seeing is that the greatest prevalence diagnosis is being seen in the immigrant population, specifically the South Asian population. Okay, and then this is one summary. This is found in the chapter, and I wanted to highlight this, which is that psychiatric disorders are highly prevalent in the IBD population. I think we know that. This report shows that studies indicate that it's about 1.4 to 2 times higher in the IBD population compared to the general population. So something that's really concerning. There is an estimate that 21% have clinical anxiety, and so they've been diagnosed with clinical anxiety, and about 15% have been diagnosed with clinical depression. They also recognize in the chapter that there is a bidirectional relationship, and I think the audience all know that as well, that between mental health and IBD itself. So you're stressed, it can lead to a flare. If you have a flare, that leads to isolation and so forth, and that can lead to mental health anxieties and so forth. So the chapter concludes by saying that mental health must be addressed in order to optimize functioning and outcomes for those with IBD. So with those findings, I'm going to switch to our Canadian healthcare system. And this is for Crohn's and colitis, but I would say for any chronic diseases in Canada. So this is where you piqued my interest, Leanne. because I think our models might be a bit different, even though we're both modeled after the UK model. In pediatric care, it's centralized at major urban hospitals. So what we know is that around 99% of children with IBD are seen at these hospitals. So, and at these hospitals, it's very much multidisciplinary care. So it's not only a gastroenterologist, but you will definitely have access to a nurse, hence the difference. You highlighted 23%. Often you'll have social worker access as well. And a lot of these hospitals, not all of them, this is something that they're advocating for now, the pediatric community, is access to clinical psychologists to better support mental health. So you can imagine, given that this is an academic-based hospital, standards of care, so their decisions are based on the latest evidence and guidelines. In the adult world, it's the opposite. So in the adult world in Canada, everybody is transitioned into the adult model when they're 18 years of age or older. It's decentralized and it's non-multidisciplinary, which means that 80% of adults see gastroenterologists practicing in community clinics, and these community clinics will be just the gastroenterologists. There's a few, just a handful, who have access to nurses, but the vast majority don't even have access to nurses. So what does this mean? There's long wait times to see specialists. Standards of care are inconsistent. So the other thing that I need to mention is Canada is large. We're the second largest country in the world, as I'm sure all of you know. And because of that, there's a big gap in care between urban and rural. So as well, the inconsistencies in care between urban and the community clinics. Just to give you an example, there was a study that was conducted out of Alberta, which is one of the provinces in Canada, on studying the use of chronic steroids in academically based hospitals versus those in community clinics. And what they identified was there was a propensity to prescribe longer-term steroid use in community clinics compared to academic sites. Lack of resources, like I talked about, which adds to the burden of the community gastroenterologist. They're alone. They have an overwhelming number of patients that they can see. And what does that mean? They can't spend a lot of time with each of the patient. At best, they're spending 5 minutes with each patient. What kind of productive quality discussion that Dr. Fiocchi was talking about can you conduct within 5 minutes? The rural and urban inequities as well. It's much harder for people living in the rural areas in Canada to gain access to these specialists because they have to travel longer. Because it's such a vast country, when we talk about travel time, we're not talking about 1 hour. We're talking about hours. We're talking about 5 to 10 hours that some of these folks have to drive to see their practitioners, their clinician. What does that mean? They have out-of-pocket expenses. They have to take time away from work, which leads to less money in their pockets. So taking time away from work means not just 1 day, it could be like a few days where they have to really plan to travel to that clinic to see their doctor and then drive back. And then, Leanne, I think you spoke about this as well, which is very similar in Canada. There are challenges in transitioning pediatric patients to the adult care model. For us, it's primarily because of the different models. In pediatric care, it's multidisciplinary, and in adult care, it's non. So because of that, there are studies out there that show that there is a huge increase in aggravating their disease, and a lot of youth who just drop out of the face of the earth, if you will, and they don't follow up with their clinicians and so forth. So how is CCC addressing these gaps? In 2016, we got together with the leading IBD centers across Canada. These are the major hospitals, to really talk about what can we do about some of these gaps that we knew way back when, and that have been identified in our 2023 report as well. So we embarked on a new research program called Promoting Access and Care Through Centers of Excellence, or PACE. And the objectives of PACE is to address gaps in care, improve health outcomes, and develop solutions that can create change in the public healthcare system. Another way to look at this, I feel I always need to present this since we are a patient organization, is from a patient journey perspective. And so another way to talk about our objectives is to really ensure that no matter where the individual is in their journey with IBD, that we're aspiring to offer them timely, equitable, and high-quality care. So, what have we been piloting? So because it is a research program, we have been collecting evidence. There's a research design behind it, and they're all pilots because we're starting small. We started with 4 pilots in 2016, and now it's expanded to 6. One of the 6 has been handed over to one of our partners, which is the Professional Gastroenterology Association, when it was time to hand it over to them. The other pilots that are still ongoing is, starting from the top left, is our My Gut pilot. It's a digital health app that we developed and launched in 2019 to support, to the point of Leanne, to empower people living with IBD. Initially, I know this was an effort with EFCCA, and it's something that we ran with. And behind My Gut, what we've done as well is we've developed a provider portal. So that there's a provider portal that's connected to My Gut, and through that, the providers can actually access all the patient data that they're inputting. And the patient data are PROs, so patient-reported outcomes, the HBI, and the P-Mayo scores. And through that, the providers can keep track of their patients in between doctor's visits to see how they're doing. This was initially piloted in 2 academic sites. There was some good evidence to show that this was effective in supporting patients better. So now what we're planning on doing, which is more of an ambitious idea, is to really support the community practitioners by offering a virtual nurse who will act as the hub and act as the triage nurse. So she will be monitoring their patients virtually. If there's any push notification coming from the measures that the patients are inputting, which is an automated way of doing it, that My Gut sends to the nurse will open up the provider portal, look at the patient's records, and determine from there what to do, whether it be more diagnostics, whether it be a phone call to have a conversation and maybe recommend they go to emergency, or whether it be to call the gastroenterologist and say, you need to see your patient sooner than later. Mental health diet and diet support. So this is something that I learned, that our gastroenterologists and our IBD nurses, one of the challenges they have is because they're not, and Dr. Fiocchi, I'm sure can speak to this, one of the reasons that they can't help support their patients on the mental health side, in Canada at least, is because they've never been trained. And secondly, from a very practical perspective, there's legal liabilities that they have to take into consideration. So because of that, one of our leading gastroenterologists, who has been working very closely with a clinical psychologist and a nutritionist, are right now in the middle of developing a tool that the gastroenterologist can use to screen their patients with a series of questions to see whether they need professional help. And if they do need professional help, then they will refer them to the professional clinical psychologist or nutritionist or whatnot. That is still running. We'll probably have it finished by next year, so we're really excited to start rolling it out nationally. We have a telemedicine program. I know it's not new to any of us since COVID-19. This was launched actually in 2016, so before COVID, and this was piloted in one province to see, is this a way that we can bridge the rural and urban gap to offer access to specialists to patients who are living in the rural areas so they don't have to drive the 5 to 10 hours to see their specialist. Again, this worked out well. There was good, strong evidence that there was savings in their out-of-pocket expenses, savings in time, and so forth. Access to the specialists, they decreased it. Average wait time was, I think, 6 months before we piloted this. And then with this pilot, average wait time went down to 10 days. So very good results. So now what we're doing in our second phase is rolling it out in each province to see, is this feasible? Because each province has small little differences in how they practice medicine, given that we're a federated nation. So we're trying to see, will this work in the other provinces? Standardizing IBD care, that's something that was piloted in one province as well, and now we're in the stage of nationalizing it to make sure that it's applicable to in all the provinces. And what we mean by that is we have all these wonderful guidelines that are developed by bodies such as ECHO, the US body, the Canadian body, and so forth, but that's done every 3 to 4 years. And one of the gaps that our clinicians identified is we need to make use of evidence when they become available, rather than waiting for the guidelines. And that's what these clinical care pathways are. We have a vast working group of clinicians and experts across Canada that have identified 16 clinical care pathways that they wanted to develop to standardize care. So it doesn't matter whether you're being seen by someone at a hospital or at a community clinic. This is a digital solution, so any practitioners can gain access to these CCPs. The last one is the youth to adult transition. We have been piloting this for 2 years, and we will be concluding that next year. So something else that we're really excited about. So essentially to say, if it wasn't clear, all of these solutions we've been working on are digital solutions. And so the idea is to consolidate all of these when they've passed the pilot stage to really bring it into a one-stop shop for both the patients, so they can gain access to all of this, as well as the provider. So essentially, I'm going to end with this figure, which essentially shows our vision of what we're trying to do with PACE, really to pilot out a virtual hub-and-spoke model that allows for that equitable access, the timely access, and the high-quality standards of care, no matter where you live in Canada and who you are. Thank you.
Do you have any question?
Excellent, Kate. We have to invite you to Australia to talk about the virtual spoken hub. You will
Absolutely.
must, because we need it desperately.
I can imagine. You're pretty large too.
It's interesting though, isn't it? Across countries, you know, you were talking about the clinical care in the paediatric area being multidisciplinary in Canada.
Yeah.
And, you know, it's the reverse in Australia. So we have good multidisciplinary care for adults. So they get access to psychologists in the public area.
Yes.
Private, not as good, but the public is the predominant. But in the children, no. So, you know, there are these differences across country, even though our countries are very similar in terms of health system, having private, public mix.
Yeah,
so,
fascinating. Well, both what I talked about, the community practice and the pediatric, they're all public. So all the community practitioners are reimbursed by our government. So in these cases, it's provincial jurisdiction. So the provinces reimburse the community practitioners. But that's one of the challenges, and hence why the community practitioners cannot hire nurses, cannot hire social workers, because in terms of their reimbursement model, it's not enough to support them.
The other thought that I had when you were talking was about how applicable this work is to chronic disease as a global problem, non-communicable chronic conditions.
Yeah.
And one of the things that we're doing is working very closely with many other patient organisations in chronic disease. So I sit on an organisation which is called the Australian Patients Advocacy Alliance, and we're all a lot of complex chronic condition patient organisations are coming together because it's helping us to advocate for system change. And we're seeing good traction with that. So that's where I'd like to make that connection with the virtual stuff.
That'd be great. Yeah. Thank you.
Thank you. And now we are back to this region. As you know, this morning we had a discussion. Ah, sorry. I didn't see.
Sorry. Someone translate for me? Okay.
Gracias. Usted habla sobre el cambio de la atención en el servicio en la infancia a la adultez y cómo hay un empeoramiento de la salud de los pacientes porque la atención deja de ser integral. En México ocurre algo similar porque a pesar de que nuestro sistema de salud está fragmentado, cuando los padres tienen seguridad social pueden brindarla a los hijos. Entonces, los niños, bueno, al pasar a cierta edad, en específico de 18 a 25 años, dependiendo del caso, pierden esta seguridad social y los avances que se tenían en el tratamiento se pierden. Entonces, usted comenta sobre, bueno, de manera general, el proyecto piloto o el manejo que se le está tratando de dar a esta situación en su país. ¿Cómo podríamos abordar de manera específica o qué recomendaciones daría usted para reducir esta brecha? ¿Qué acciones podríamos tomar? Gracias.
So thank you for that question. We're not tackling it from a healthcare system model because we felt that that's a big battle. So what we decided to do is come up with something that the youth themselves can take control over. So essentially empowering them more. So it's a psychosocial model that we're testing. So it's about, I don't know who talked about resilience. I don't remember the speaker who talked about the importance of resilience amongst youth. And that's what we're essentially doing. Our model is all about education, coaching them. We have social workers. So again, it's a virtual model. So virtual navigators who essentially are doing the hand-holding, if you will, of the youth and ensuring that they learn all these aspects that evidence has shown is important for them to successfully transition into an adult care model. And I think that's something that any country can adopt.
Yeah. I'm sure we can then discuss a bit more about transition from childhood to adult care because it's something that was common in several presentations and in general into the discussion. But before sitting on stage for the panel discussion, I would like to ask to the rapporteur who is the rapporteur of the discussion among Latin American countries? Maybe Beatriz? I think it's your turn. It's okay? So please, let us know what you discussed and which are the common points you would like to share with the rest of the audience.
¿Subimos aquí al podio o no? Bueno, yo voy a hablar en español. Escuchando las previas presentaciones, creo que coincidimos, no sé, estoy hablando la verdad sin preguntar, pero viendo a Carolina, a Tati, ¿no? Creo que sí hay una diferencia entre la región de Latinoamérica contra otros lugares. Y entonces, lo primero en lo que coincidimos, que creo que fue lo más importante, es que sí tenemos que estar unidos. Como decía el profesor Claudio, o sea, uno puede tocar y no lo van a escuchar, a que si somos varios unidos, entonces llegamos a la conclusión que nos tenemos que unir como región y tenemos que tener un paragüitas, ¿no? Que nos cubra, que nos asesore y pues ese paraguotas va a ser EFCCA. O sea, como que sí nos da un peso. A nosotros como asociaciones pequeñas no manejamos los números, ¿no? Del Crohn's colitis de Estados Unidos, ni los números de Canadá, Australia, ni siquiera, o sea, muchos de sus trabajos de investigación, de desarrollo, ¿no? Entonces, concluimos que se necesita estar unidos bajo el EFCCA, que eso nos va a ayudar. Que necesitamos crear datos. Otra cosa que platicamos a nivel regional que realmente no existen registros nacionales por país. O sea, es muy difícil. Existen estudios epidemiológicos que alguno ha hecho, el de Uruguay quizá, que ya tiene tiempo, ¿no? El de México con el doctor Yamamoto, que fue, o sea, un estudio muy concreto. Entonces, necesitamos crear registros para generar los datos duros, ¿no? Estos datos duros nos van a llevar a hacer incidencia en política pública. Esta incidencia en política pública, igual, si nos unimos como región, va a tener más repercusión que cada uno en lo individual. Tenemos que, como decía también el profesor Claudio, o sea, que todo radica también mucho en el empoderamiento del paciente. O sea, que si es un paciente que pierde el miedo al ir a su consulta, que llega hablándole de tú a tú al médico y preguntando, oiga, estos nuevos tratamientos, yo he notado esto, leí en esta bibliografía, ¿no? O sea, es diferente el trato, por muy corto que sea el tiempo de cita, de consulta, a un paciente que permanece callado y nada más escucha y es pasivo. O sea, necesitamos ir transformando a estas personas activas en su salud. Necesitamos crear alianzas con las agencias regulatorias, pero igual, como decíamos, hay países tan pequeños, ¿no? O que los números, quizá no es el país y la cantidad de habitantes, sino los números para las farmacéuticas no representan, ¿no?, grandes números, pero si nos unimos puede ser también diferente porque ya nos ven como región, no solamente o sea, como país. Sí dijimos que nos tenemos que llevar una tarea, o sea, no podemos, como decíamos, ay, o sea, qué bonito, qué padre reunión, nos reímos, comimos muy rico, o sea, necesitamos tener nuestra tarea. Una de ellas fue reunirnos virtualmente, por lo menos una vez cada 3 meses, o sea, así tengamos la cita que tengamos, no podemos ir faltando porque tenemos que tener compromiso para sacar esto adelante, ¿no?, como región. Entonces, esa es como la primera tarea, crear alianzas con agencias regulatorias, contacto directo con los científicos, los pacientes. Tenemos que influir en la academia. Eso es algo que también, o sea, los pacientes solos, pues es más difícil el trabajo, pero si tenemos a los médicos de nuestra parte, pues nos van a escuchar más, ¿no? O sea, vamos a estar mejor oídos. Y, por ejemplo, lo que también vimos, y esto es lo que sacamos también de provechoso, que aprendemos, o sea, no nos podemos, estamos saliendo de aquí con muchas enseñanzas y prácticas que podemos replicar en nuestros países, de los países que ya nos llevan años de ventaja. Entonces, ir copiando y copiándoles, ¿no?, esas prácticas que llevan, que les han dado resultado a ustedes, llevarlas a cabo en nuestra región. Respecto a los ensayos clínicos, ¿no? O sea, tenemos a DIVA, ya Roberto en la mañana explicó todo o sea, lo que nos puede dar DIVA, entonces aprovecharlo, si ya está ahí, ahora sí que sacarle provecho. Por favor, ayúdenme, porque no me acuerdo, no soy muy buen, difusión, o sea, ¿alguien más quiere subir y compartir? Carolina. Que te pegues el micrófono para que...
Sí, la difusión de cómo hacer más visible la enfermedad y que sea una difusión grupal, que todos vayamos bajo la misma, bajo la misma línea, que todos transmitamos lo mismo a nuestros pacientes, a nuestro gobierno, que sea más visible, y con la ayuda del EFCCA yo creo que podemos lograr tener éxito en esto, hacer que cada vez seamos más grandes siendo países pequeños y no desarrollados, pero que podamos dar una gran ayuda a los pacientes.
Yo los veía hace rato muy participativos, que hasta nos esperaron afuera para comer cuando estábamos sentados aquí en la mesa, y ahorita que sabemos que tenemos el micrófono, como que nos cohibimos un poco. Bernardino.
Sí, hablábamos sobre la importancia de crear conciencia en la academia cuando los médicos especialistas se están formando, para así incidir también en que conozcan la enfermedad, porque no todos los gastroenterólogos conocen de Crohn y colitis ulcerativa. Entonces es bueno abrir ahí el abanico para despertar el conocimiento o la especialidad o el interés de ver estos pacientes dentro de la especialidad de la gastroenterología, porque mucho, si ocurre en varios países de lo que estábamos presentes conversando, que llega a la consulta de un gastroenterólogo que no es especialista y no es capaz de diagnosticar una enfermedad y se va atrasando el diagnóstico, que es uno de los problemas más frecuentes en nuestra región y quizás también en parte de todo el mundo. El diagnóstico es muy, muy complejo, y también salía la idea de hacerlo en la malla curricular de los médicos en general, pero ahí se nos abría demasiado la distancia y era mejor focalizar hacia acercarnos a la especialidad.
¿Se acuerdan que Roberto como que planteó cuando estábamos en la mesa la discusión de que decía, a ver, todos tenemos, o nosotros como región, y creo que también lo compartimos con los demás países, el problema del diagnóstico, ¿no? Que queremos que sea rápido y que tengan acceso a tratamiento lo más rápido posible, y que decía Roberto, ¿qué tan factible? O sea, van a quemar realmente todas sus energías en eso que va, o sea, que es una lucha que todos venimos haciendo ya hace tiempo atrás y implica muchísimo esfuerzo. Entonces, ¿qué dijo? Concéntrense en lo probable, o sea, no, pues sí, un poco en lo inmediato, ¿no? En lo práctico, o sea, entonces por eso como que dijimos y de ahí fue que salió, tenemos que hacer difusión, porque es el mismo, o sea, es la misma, a mí no me gusta usar la persona paciente, ¿no? O sea, por todo lo que, la connotación, pero es la misma persona diagnosticada la que tiene que involucrarse y participar para, digo, no, ya también ya no voy a hacer lo del circulito, eso ya también ya lo he usado mucho, pero somos nosotros, o sea, somos cada quien en su casa, con su familia, con su doctor cuando va a su consulta, en su escuela, en su universidad, en su trabajo, los que tenemos que empezar a hablar de esta, ¿no?, enfermedad, empezar a compartirla, perder la vergüenza, quitarnos lo que creemos nosotros que es este estigma. Empieza el trabajo, o sea, tiene que ser personal, y para que se vayan haciendo olas, y quién más, o sea, como que siento que trabajamos más, y me estoy quedando como muy corta de todo lo que dijimos.
Sobre la divulgación o la difusión, es importante porque colocaba yo como ejemplo, en mi país, hace 10 o 12 años no se conocía prácticamente la enfermedad, y fue trabajo de la Asociación de Pacientes la que llevó primero a trabajar en una ley para poder tener cobertura para tratamientos de alto costo, y ahí recién algunos médicos especialistas o gastroenterólogos se dieron cuenta de la importancia que tienen los pacientes o las agrupaciones de pacientes, y pudimos despertar el interés en los médicos gastroenterólogos y así que ellos mismos se fueran interesando en dedicar parte de su tiempo y de su especialidad a atender a las personas con enfermedades inflamatorias intestinales. De la misma forma, los tomadores de decisiones, como decía un exponente anterior, que la rueda que no chilla no se aceita. Y es muy cierto, porque también cuando las agrupaciones de pacientes convocan a pacientes, convocan a personas, es bueno tratar de tener el respaldo de las personas con los problemas de salud detrás de las agrupaciones de pacientes, porque a los tomadores de decisiones les interesa la participación ciudadana y también les interesa ver que hay mucha gente detrás pujando para sacar adelante estas tareas y se interesan en eso.
Sí, yo creo que...
Just a moment, because you know we are supposed to have the panel discussion. So, no, I don't want to stop you. I give you 5 minutes, and then we start with we ask to the rest of the panelists to come on stage, okay?
Just 5 minutes more?
Yes, please. No, it was just to reorganize the rest of the conference.
No, yo creo que lo más importante y a lo que llegamos con todos los puntos que hemos tocado es que la difusión y la unión grupal como región es lo que nos va a ayudar a hacer que esta enfermedad sea visible, que haya un diagnóstico temprano, que podamos estar todos bajo un mismo... bajo una misma línea, que todos estemos igual, con el mismo enfoque, haciendo difusión de lo mismo. Es creo que la conclusión a la que podemos llegar de difusión, un diagnóstico temprano, unión como región.
I see. I think that, I don't want to interrupt you, but I think this is a concrete example of how we can work together. So it was a few hours this morning, we have the chance to work together, and now you are here sitting together and spreading your message. I think the most powerful message we can get from this moment, really united. So take a picture and a big applause. So now I have the task to ask our panelists to sit on stage, please. And where are you? Beatrice, you should jump on as well. Yes. So he's missing. Roberto, okay, and Claudio. So we have just not a lot of time, and also I have to confess that it's not easy to start and to, how can I say, find something to ask you as a starting point, because so many issues and so many commonalities and interesting point has been discussed and presented. But I think that I will start from 2 main elements, and then you will pass the floor, and I just want to have few comments from all of you. One is about empowerment. This was something that was treated from different angles, but the role of patients in any moment of his journey, and sorry, I don't want to use patient anymore, a person with any chronic disease, in our case is IBD, has to be at the center, has to understand what he or she is experiencing, his rights, her rights, and whatever is necessary to handle the disease. So concretely, because I hope that at the end of this roundtable we will be able at least to identify some common points that then we can then develop. What do you think it's important to start or to reinforce the empowerment of a person that is experiencing a chronic disease like IBD. You start? Okay, Liane.
Thank you, Louisa. A very important step is to encourage people to tell their stories, to talk about their story and what is happening to them. And we find the younger generation is very good at it. They're excellent. We have at the moment a social media campaign, and listening to the children talking about their IBD, it's wonderful. It's just so inspiring. And with the older generation, we are encouraging them to tell their story in writing in our magazine as well, and getting their lived experience through different ways, because they're not necessarily willing to do that publicly. But that will change over time. And I think that's a really important step of raising that awareness and a step towards empowerment for individuals. But the other key aspect is there's two other important areas: making sure you have really good information so that you're working on health literacy of your community. And the third thing is having resources that help people better manage their care. So we've developed plans that they can use to make sure they have all the information in one spot, and have it to take when they have clinical consultations, to understand what to do when things go wrong.
I think this is going to be a yes and, because I agree with everything you just said, Leanne. And I'll add on that patient empowerment is a journey. And so we can't expect a patient or a caregiver or anyone to immediately be ready to tell their story, or be ready to have a very candid dialogue with their healthcare professional. We have to recognize that we need to think of it as stages, and give them the resources to become comfortable, educated maybe first, then give them the tools to talk to their healthcare professional, then give them the tools and the peer support to give them the community, and then start to tell the story, and ultimately empower them to take action, whatever that action is. If that action is legislative, if that action is going and working to be a patron-centric sponsor and on social media and become a thought leader, but it's a journey. And the other thing I would say, in addition to health literacy, we have to take into account cultural competency. So being sensitive to the different cultures within your community and making sure that whatever support, education, research, advocacy that you're doing reflects the unique needs of that community. And so I would caution, this is a journey and it takes time. You can't tackle all of this at once.
I really think it's going to be yes to everything, and we want to add. So yes to everything, absolutely. And I fully agree, Leanne, there's such a difference with the younger generation in terms of them being out there and talking about their disease. And historically, that's one of the challenges we've had in IBD, where it's, I don't know what term we could use, maybe an invisible disease, because not only there was lack of awareness, but also the people living with their disease, they didn't want to talk about it. But we're definitely seeing a shift with the younger generation. What I wanted to add was just about the resources that both of you talked about. And this, Louisa, you talked about patients or people living with IBD being in the center. One simple tool is one that we have available, because speaking about the differences, there are some people who are very good at advocating for themselves and very good at maximizing the 5 or 10 minutes that they have with their gastroenterologist. And that was a learning process for them in terms of, well, how do I do it? Definitely they had to educate themselves about their disease and look at all the resources, actually learn about medical terminology as well. So working with these type of people within our community to develop a guideline, if you will, a very simple discussion guideline, that anyone who might not be quite there to use, to be able to have that ready so that they feel that they're ready, confident, so they can hold that productive discussion with their clinicians. I'm sure you all have one of those as well, but just wanted to give that as an example since we're talking about developing something with patients.
Fine. No, I also agree. However, for saying something different, something that I have been thinking about in these last years, for first time something is changing. I started to notice how we need to change our expectation. We have been asking others to put into our shoes. And now, for first time, there are other stakeholders asking us to put into their shoes. And this is really interesting because we need to learn what others expect from us so that we can support them to help us. So this is new. We need to learn that, and we need to understand how we can collect information, meaningful information, so that they can make with us a better decision on behalf of our community. So this is a challenge. This is something we need to solve, and of course, need to understand how to deal with.
So I will add my 2 cents. So I see empowerments at 2 levels. If the patient is empowered because studied, learned, feel more comfortable, and can talk to the physician like, I want to know more, tell me something, that is fine and great. But empowerment also has to be translated into representation. If let's say we are all patients and each one of us feels empowered. But how do we translate this empowerment to an organization where we can actually make something happen? The doctor cannot make that happen. So we need representation, and representation implies to have leadership. So whatever group we have, somebody has to be the one that takes the helm and say, okay, we all agree on this, we all have our thoughts, and now we're going to go to agency X, Y, and Z and say, we are and we want this. And be ready to say, that's great, but that's going to be difficult. But the journey is difficult. But representation, and this is something the US is very good about it. Sometimes for the wrong reasons. And often for the wrong reasons. But representation is fundamental. Translate my empowerment, your empowerment, to a voice that can be heard at a government agency level.
Go, Beatriz.
Estaba pensando justo eso, o sea, veo la página y los invito a ver la página de Facebook, de Instagram. Las personas realmente quieren compartir su historia y la comparten y lo hacen. Y si tú te metes a la página ves que son los que tienen more likes, o sea, más que la plática del especialista. Y es justo eso, cómo se hace que todas esas personas que comparten su testimonio llevas la representación a otro nivel. O sea, ahí es donde las barreras, ¿no? Quizá a lo mejor los tiempos políticos de cada país, ¿no? Actualmente mi país, ¿no? Está, o sea, en 15 días va a haber elecciones, un sistema de salud fragmentado. O sea, estaba en las mesas que tuvimos en la mañana, hablaba Uruguay, Colombia, todos tienen un sistema de salud. México tiene como 8, o sea, tiene muchísimos. Entonces, ahí es donde, ¿cómo le hago? ¿Cómo le hago?
I think this brings up the issue of leadership. Leadership is not for everybody. You can be competent, you can agree, you can support, but the ability of gathering the ideas of your peers and unify them and able to translate those feelings, those desires, and those demands into cohesive, functional, and credible words is the quality of leaders. There are many leaders in this world. Most of them are no good. Yeah, we have plenty of evidence everywhere. So I think there should be the responsibility of, to start at least individual national associations for IBD to choose somebody that is willing to represent the thoughts of the patients and be able to have the ability to transmit this, and especially in Latin America, have the right connections. Because in Latin America, everything works a lot through, I know this was a friend of mine, who was a friend of that, who was a friend of that. In the Anglo-Saxon countries, so to speak, or the Commonwealth country, as I call them sometimes, it's not quite like that. But in Latin America, it's fundamentally. That's the way you get things done. So, again, the solutions must be like treatment for patient is customized. The approach to the agency, to the government, must be customized on each country.
Laura, and then Roberto.
I'd like to just add, I think trust is really important to establish with your community. And you spoke about the Facebook leader often having the more views than the physician leader. Reaching out to them, understanding them, asking them to join you is one great way. And then building trust within the community because you're listening to them and then taking actions based on their feedback is an important first step to the collective action and really motivating and supporting the community. Just something I wanted to share.
Roberto, you wanted to add something?
No, just for adding something, for answering her. I'd say, in Spanish we say, hay que echarle cara. Because sometimes I have been many times how patient representative, even with a good connection with the seat and the micro to speak in the right meeting, at the end they remain in silence because they are ashamed. They don't want to make a mistake, and we are entitled to make mistakes. Maybe we can allow us to give them an incomplete answer. That is better than to be quiet. So we shouldn't have fear of that.
Okay, and then since we only have a few minutes to close, just a quick reaction.
Comment?
Yes,
Quick
yes,
comment.
yes.
Okay, good.
No, feel free.
I just want to mention the word advocacy, and I think every organisation, because we do a lot of work with Asia as well, and lots of countries that don't have patient organisation. Every patient organisation must have an advocacy program. And what I would say, a smart advocacy program. So you need to understand what is important that you want to achieve and think about how to engage your community, whether that's people with IBD, their families, carers of people, or the health professional groups. They will come in and you can advocate with them in certain ways.
Yes, I think that this is a classic example of starting from different experience and different stages of, for instance, advocacy. We can learn from each other and we can see also adapting approaches, activities, because we need to consider that, as you mentioned, in Asia, for instance, there is no patient association. But patients have needs and have needs there, as in every other country. So I think that this is an example on how we can really exchange and try to adapt what we are learning or what we are teaching from one country to another one. I was saying earlier that it's difficult to try to find, no, there are a lot of communalities, but to decide which one I want to put on the table and see how we can conclude this day. I just want to suggest That is something that is transversal to advocacy, to networking, because I heard from you that it's important to establish a peer relationships with the physicians, but also to have good connection with medical societies that can help the community, the patient community, to identify not only the needs, but the solutions, because we are all here also to find solutions to improve quality of life, and I stress quality of care, but also very important quality of life, because it was said in several of your interventions, you can have the better care, but you are still miserable. So this is something, again, that has to be taken into consideration. So I'm wondering if trying to be more visible, that means that visibility has a different meaning in different countries, but also in different stages of the disease itself. And we know, for instance, that young people maybe are much more proactive when it comes to break the silence. We know that elderly people have more difficulties because it is what it is, because they are not used, but not only when it comes to talk to IBD. So, and I also heard, and it's connecting to that, getting more visible maybe means to becoming a global voice that make this invisible visible. That doesn't mean that we have to have all common programs or everything common and etc. But maybe starting from this basic rights. I have a disease. I want that my disease is seriously taken into consideration, even if I look fine, smiling, and it seems that everything is okay. And it means talking to physicians, to having this is also something that was discussed and presented several times. I want to have the most effective and capable psychological support. I want to have a group of physicians and experts. We didn't talk a lot about diet, but this is another aspect. We really need to claim these rights in a global way, because this is something that was common to all your presentations. So my point is, shall we think about getting less invisible together?
Okay, so obviously, what you propose, nobody will disagree with that. As we say, the devil is in the details. Great idea. How do we do it? I think one important level of action is being realistic about what you or your society can achieve. You cannot demand drastic changes because those don't happen anywhere. But sir, I think that at the society level, and in a different way depending on the country and so on, this visibility must be defined, and how to become visible, acted upon. And that visibility, no matter how big or small, should be brought to the agency, to the government. And see what kind of success you have, what kind of feedback you get before going globally visible. That's a pretty hard thing to do, become globally visible. So I think that I agree, but I think we should start at the local level, and we improve as we do it, and then once we feel that you have the tools or the representation, the answer, and you have some degree of success, share with the other societies, and then devise mechanisms which are common to all of them. This is going to be a long process, but if you don't start, it will never get done.
Absolutely agree with those comments. One of the things that we do in Australia a lot is we dream about things. And when you look at non-communicable chronic diseases, you know that at the global level, at the World Health Organization level, this is a huge problem for the world, growing problem for the world. And we don't have a voice there. So, I would like to think that we could even establish a network across continents in some way where we could start to talk about how we create a voice. I have seen it happen, and been involved in other areas. And that was in the stillbirth area in paediatrics. So there are ways of doing this. The other thing I make a point on is we have World Health Organization goals. We sit neatly under that. So, you know, we need to think. We've had a recent publication in The Lancet talking about the burden, global burden of IBD. Don't know if you've all seen that. If you can get hold of it, you should, because they're clinicians, researchers, epidemiologists across the world who have come together to put in a framework. So clinicians are working globally. So as patient organisations, we need to think how we can do that.
I am going to do the yes and again. I agree that the World Health Organization is a great step to consider making our diseases visible. I also appreciate the point of making them visible at the organization, country level. But I do think there could be an opportunity to come together with the right leadership, to Claudio's point, to come up with a visible Bill of Rights or something like that that we could all agree to and you know, ratify, so to speak, across our different countries and organizations. So I do think that's a noble cause along with these other efforts. So I would be supportive of exploring that. And having more meetings like this to share best practices and resources, because there's so much that many of our organizations could share as best practices and accelerate the work of some of our fellow sister organizations much more quickly by sharing.
I don't think I have anything to add to that. I was going to say, I think we're on a good start with EFCCA turning rebranding to IFCA. And I think, and EFCCA has been leading the way in terms of, you know, uniting everyone across the world. And I do agree with everything that's said. We need the proper leadership. But I'm a strong believer in the collective voice. So for us to work together, I think we can make more impact globally than individually. Yes, we have to do things individually because our nations, the way we function, it's very different. But that's not to say we can't do that in parallel. So to Laura's point, I think this is a great forum for us to get together, share best practices, and that's a great way to accelerate and help each other in sharing resources and, you know, identify, you know, what are you doing? What am I doing? And talk about that and see how we can collaborate and say, oh, wow, we're not doing that. Can we borrow your resources or whatnot? So have those types of conversations in this forum.
I agree. In short, we can miss this opportunity. We can miss this opportunity if we see what others are doing. National governments are collaborating each other. Evaluators are collaborating each other. Physicians too. No, but they are collaborating. So we need to do it. It doesn't matter how, it doesn't matter who can lead it. The important thing is this is a global issue. Health systems are suffering with the same problems, and we can find a common solution. So we need to try it.
Así como existen países grandes y países chiquitos y hay unos que tienen más representación, ¿no? Y votos en la ONU y otros no y todo, estoy totalmente de acuerdo con ustedes y creo que los chiquitos o la organización chiquita, no se trata del país, sino de los que apenas vamos empezando y vamos, ¿no? Tratando de, o sea, de estas buenas prácticas, de tratando de copiar y todo. Yo me apunto a ser un aprendiz, o sea, yo me apunto a estar globalmente, ¿no? Unida, y es más, por eso propongo quién va a ser la próxima reunión y cuándo. O sea, no nos podemos ir sin decir, o sea, ¿cuándo nos podemos volver a reunir? Quizá ya no vamos al World IBD, pero, o sea, vamos a, ¿no?, a comentar buenas prácticas y a lo mejor con un compromiso que cada asociación haga, por muy chiquito o grande, pues ahí ya empieza el camino. ¿Quién quiere?
Wow.
Tenemos que recaudar fondos también para eso, pero pues para eso también.
So, going back to the theme of leadership and representations, what I hear is that we need to have a new meeting, discuss more, bring more people in. At this stage, I think the best way of doing that, at least for the time being, is asking still EFCCA to do it and be responsible for before becoming IFCA. Because before all the other societies organize themselves and bring speed to the process and get together, somebody has to keep going. And I think EFCCA is the best to do it, is the most qualified, simply because of experience. There's a lot more experience. So, at least for the time being, it's on your shoulder.
My second name is Atlas, no worries. No, I'm joking. No, I'm looking at the president because I just want to see his reaction, and then we need to conclude, but if you don't mind, since we are the chairman here, I will give him the floor for a couple of minutes.
Just 2 seconds to say that today we were very inspiring. We found a very great ideas. And of course, I'm going to close this event answering Claudio's question. Yes, EFCCA will become international. And in my opinion, we should become an international organization where there are all full members and non-associated members until now. So all the country entering will be able to vote and to decide what to do in their organization. It's an open box. Thank you so much.
So we have the full endorsement of the chairman of EFCCA to start this process together. I can't make any conclusion because we are just at the beginning. So I think it's not wise to draw conclusions. And if you all agree, I would just put together a couple of points that could become the recommendations. One is keep a continuity of this type of exchanges. They could be online. I know that the Latin American group was already thinking about having another meeting online, etc. So I think that, and we can help in keeping alive the network. I think this is a treasure. We can't just leave it in Mexico City. It's fine. I'm not nothing against. But I think that we need to keep on working and developing the common points and keep on learning and building something together. So if you all agree, this is the next concrete step we can do, and we can then decide. We will draft a report that we will circulate it. And it's not a conclusion. If you want, you were saying, Liane, that we are visionary. Yes, I want to be, we need to be. So let me think about, in the next couple of years, or maybe less, to a global forum of all of us working together, being more visible, and really trying to represent all all people with IBD, no matter the severity of the condition, the availability of drugs, and the challenges that each of them are living in their countries. In that way, we can really make the difference. And I hope that you all agree on that, and we keep on rolling and seeing which way we can do better in the next years. This is my suggestion. I hope you're all right. And I have to thank you all for your kindness, availability, and the passion you have been putting in this day. I also want to thank someone who is less visible, even less visible, that are the technicians that make this available. I have to say, but when you talked, Laura and Liane, we cut the streaming because you wanted the confidentiality. But meanwhile, we got several input from the rest of the world. Our friends in Denmark, okay, great, it was great. Italy says, so there was someone, and in Europe it's very late, but someone was following us, and they were very, very happy. So thank you to the technician that make it possible. And over there, there are the translators that we really need to thank, because you are facilitating the exchange. That is really an important aspect. And I would also like to thank those guys that have been discreetly serving us all day long with water, coffee, and everything. So muchas gracias. Muchas gracias. And now where is Beatriz? Ah, you are there. So can you give us the last instructions before now? It's not finished. Huh? There are other things to do together.
I don't know what time is it.
5:15.
5:15. Okay, the bus will take us to the Castillo de Chapultepec. It's very near, 15 minutes or less. We have to be there at 5:30 in Leibniz Street. It's not in the front, not the lobby entrance. So at the back of the hotel, there's another hall, and you see if you want, we can meet it at the lobby, 5:30, and then go to Leibniz Street. We will take a scholar bus, and that was the economic. And then to take us to the Chapultepec Museum, then a guided tour, just maybe 1 hour. And we can over there see Paseo de la Reforma, that it's a very important street, the avenue in Mexico. And also it will be illuminated in purple. De Ángel de la Independencia, el museo, so we can take a lot of photographs, and that's the beginning to do awareness, IBD Day. Okay. So if you want to change clothes, 3 minutes.
So start running. Wait a second, we have a wedding picture as usual. Come on, we need a picture. Don't move. All participants, please. I don't know, do we have to stand up, boss? She's the boss, you don't ask me. Okay? Salvo, come. Rocio, come.